So the title of my talk is Pediatric Hearing Loss, Ear Tubes to Implants, and something that I'm very deeply passionate about. I've partnered with Dr. Preciado and am now work with him as a cochlear implant surgeon to try to identify these children early on, because the data has shown that with early intervention with either amplification in hearing aids or ear tubes or, for instance, cochlear implants, which is what I'm most passionate about, we can make a really amazing positive difference for these children. So the significance of this, I think, is well said by Helen Keller, who said, blindness cuts you off from things, but deafness cuts you off and isolates you from people. And individuals who are deaf, who have impaired hearing, can feel very isolated, and that can result in feelings of depression. And so it's important that we reach out to them. Children in particular, it's hard for them to oftentimes voice their frustrations. So as pediatricians, it's important for us to really advocate for these children. So the outline of my talk today is going to be to sort of delve into a little bit of universal newborn screening and just how beneficial that program has been in terms of identifying these children early on so that we can intervene by the time this child is 6 months of age. Because by intervening by 6 months of age, we've shown that these children can do remarkably well, that they can talk like you and I, they can be aided with amplification and hearing aid early on, they can be get excellent therapy from our speech and language therapists. I'm going to talk to you about some of the triggers and alarms that should go off in your head that should allow you to get other specialists involved, geneticists, ophthalmologists, perhaps send a child with hearing loss to see us in Otolaryngology. I'm going to touch briefly also on the workup, which, as I'm sure you guys are well aware, the workup used to be pretty exhaustive and oftentimes didn't result in answers that were very helpful for the families, a lot of expensive tests. And as Dr. Weissman had mentioned and Dr. Newman had mentioned last night, we're trying to get away from unnecessary expensive tests. But recent advances in imaging and in genetics allow us to determine the underlying etiology, which can have prognostic information. It can let us counsel these families and let them know whether, for instance, this hearing loss is likely to be stable or whether it could perhaps get much worse. And finally, I'm going to touch base or conclude the talk dealing with some of the surgical updates. Cochlear implants. We're now implanting children as young as 8 months of age at Children's National. The BAHA, and also talk about progressive hearing loss. And finally conclude with the new frontier of stem cells. So the incidence of profound sensory neural hearing loss is quite common. It's 1 to 2 per 1,000 live births. It's actually 10 per 1,000 in a NICU. There's also another 1 to 2 per 1,000 births with moderate hearing loss. So these are children who would benefit from amplification and speech therapy. And then this translates for you all into about 33 babies born every day and about 12,000 babies that are born per year in the United States. And if you look at the patients that you sort of manage in your practice, you see many of them obviously with frequent otitis, with chronic effusions. Those are the more mild cases, but the average pediatrician will see in their practice about 12 patients who have profound or moderate or severe hearing issues. So we screen for many abnormalities, and I think that hearing loss, as you can see, because of its prevalence of around 1 to 300, it really makes sense, and we can have a great impact. And the goal of the universal newborn screening is sort of to keep in mind is this 1-3-6 approach, which is that all babies should essentially be screened by 1 month of age, and then those children who refer, which is sort of the new terminology for failing, but refer who do not pass that initial test, should then get repeat audiologic assessment by 3 months of age, figure out where they fall, so that we can intervene by 6 months of age. One of the old sort of myths was that, well, we can wait till the child's 1 or 2 to sort of put on hearing aids, but data has shown that their auditory cortex is so primed to get the speech acquisition early on, to get that sound stimulus early on. So we want to be aiding these children by 6 months of age. And we have special bands that audiologists can put around the child's head that are comfortable, that allow that child to wear that hearing aid and actually enjoy that hearing aid. And one of the nice things about technology is that it allows us to do the rapid screening. That allows us to do it in a quick, reliable manner. This picture here shows a woman doing an insert into a child's ear, and basically a sound is emitted and then an echo stimulus occurs, and that's what the otoacoustic emissions test for. That's the initial screening. If that child does not pass that, then the child will go on to get an ABR, which assesses a brainstem response and auditory waves there. And the children who are diagnosed early on with severe to profound hearing loss are now being implanted as early as 3 months of age in places like Europe and Italy. In the United States, they're being implanted as early as 6 months of age, and studies have shown that children who are identified early on and get this early implantation can develop normal spoken language by the time they're in elementary school. That is, of course, the big caveat being with lots of therapy, with parents that are highly involved, and without other sort of neurological sequelae. But the auditory cortex, as I mentioned earlier, is really primed to be able to use that cochlear implant in a way that allows them to have a conversation like I'm having with you right now. So many people feel that, this is sort of an old fallacy, that the universal newborn screening was going to result in too many referrals, too many abnormal false positives. But the reality of the matter is that of every 1,000 babies that are born, there's only about 12 that do not pass. So that results in about a 1.2% refer rate or failure rate. And of those 12, so if mom comes to you in your office for the first well baby visit and says, well, my child did not pass this initial screening test, what does this mean? And can you please tell me about it? The first thing is to sort of reassure her, but to also emphasize to her the importance of not brushing it aside, because more tests are necessary. So and the first test is to sort of repeat that with an audiologic evaluation. So of the 12 per 1,000 that fail, there are 3 that would have a permanent hearing loss. That's something that would require hearing aids or a cochlear implant. There's 7 to 8 that would have normal hearing. So the odds are quite favorable that the repeat test will show that this is something just transient, or that it was a false positive. And 1 to 3 would have conductive hearing loss, which is transient. Most babies can have fluid and resolve spontaneously. So universal newborn screening has been present now mandated in Maryland and Virginia in 2000, mandated in Washington, D.C. in 2001. And it helps us to identify these newborns early so that we can achieve early intervention. But I want to stress this one point, which is that it does not capture all children. In fact, there's a whole subset of children who have postnatal onset of hearing loss. And there's a study that I'll share with you later on that 33% of children that we're implanting today actually have progressive onset, rapid onset of hearing loss after birth. So they pass the initial hearing test, but something happens to those very sensitive hair cells early on that causes them to degenerate and result in significant hearing loss. I think the national universal screening has been an excellent example of how healthcare policy can really positively impact children. And you can see back in 1999 when we were just assessing children who had high risk factors, children, for instance, who were preemies in the neonatal intensive care unit, had been on ECMO, we weren't capturing all of them, because 50% of children who have severe to profound hearing loss, 50% of them won't necessarily have any risk factors. That's why it's important to do the universal screen. And we're getting better, although not all children, for instance, will be screened upon discharge of a hospital. Sometimes the equipment's not working right. Sometimes a child, for instance, has a home birth, so it's important to reinforce the parent if the child has a home birth or is born at a birthing center where they don't do universal newborn screening to seek that out. I touched on infant hearing loss, but I also want to address pediatric hearing loss. So many children, for instance, can have degeneration or insults from infections that can cause them to have further deterioration of their hearing loss. And so we talked about how in infant the risk is 1 to 2 per 1,000. Well, by the time that child enters elementary school, it's up to about 6 per 1,000. And you want to identify this in elementary school because so many studies have shown that children who do not hear well are underperformers. Even unilateral hearing loss has really adverse consequences. So something that's really minimal hearing loss, unilateral hearing loss, it's not inconsequential. It makes a huge difference. Children who have single-sided deafness have a 10-fold risk of being held back 1 grade. They have decreased academic performance. In 37% of cases, they can fail a grade. And then a lot of teachers can mislabel these children as being attention seekers, as being troublemakers or daydreamers or having ADHD. This can have adverse psychological effects on the child, make it harder for them to do well in class. So we always emphasize that any child with hearing loss should be seated right at the very front row of the classroom. There are a lot of common myths that are out there that we assume that parents will bring hearing loss to our attention, but the reality is that we have to sometimes ask the tough questions about how that child's doing in terms of their speech and language in order to uncover that there is perhaps a delay or a deficit. And so many people sometimes assume, well, parents will just know that their children cannot hear. And studies have shown that parents oftentimes will not recognize it until the child's 2 or 3 years of age. And remember, we want to try to intervene by the time the child's 6 months of age. So if we just wait for the parents to tell us that their son is not talking, it sometimes can be too late. We touched on the fact that it doesn't lead to too many referrals. In fact, the refer rate is low. It's 1.2%. And this idea that there's no rush to identify it is not true because our audiologists are able to aid children as young as 6 months of age with very nice hearing aids that look a lot like the Bluetooths that are now in vogue. And we don't want to just only screen the high-risk children because that'll miss over 50%, over half of the kids who may, for instance, need a cochlear implant or who may really need the hearing aid in order to do well. So the big red flags are parental concern. In fact, there's sort of a saying that if a parent tells you that they feel that their child cannot hear well, that you should assume that child has hearing loss. Work off of that premise, which means it's very important to get audiologic assessment. It can be very difficult to assess a child's hearing loss just by clapping your hands, for instance, because children are so keen on looking at behavioral cues, shadows, following parents. So audiologic data is critical. Any child who has syndromic features, there's a much greater risk of having hearing loss. Torch infections, or toxo. Really the big one in the TORCH acronym is CMV, and I'm going to touch on that later on. And degenerative disorders, muscular degenerative disorders, as well as a positive family history, which means a parent, for instance, who had early onset hearing loss under the age of 30, or a parent or a distant relative who has profound deafness. What is the workup that we need to do with you guys? And many pediatricians and healthcare providers felt that we would order all these bloods and most of it would come back negative, CBC, thyroid studies, electrolytes. The first thing is really just getting a careful history, making sure that this child doesn't have the risk factors of being in the neonatal intensive care unit, intubation, things of that sort, perinatal infections, hospitalizations, previous history of meningitis is a huge risk factor. On exam, we want to look very carefully at the ears, look for other anomalies, skin tags, microtia, abnormally shaped pinnae. small heads, microcephaly, other dysmorphic features can allow us to think perhaps this child has a syndrome and we need to get a geneticist involved. And then we want to partner with you, not only in ENT, but also we work closely with genetics for all of our genetic testing, the neurologists, and the ophthalmologists. And it's important sometimes to consider getting EKGs in these children because an electrical conductive abnormality in the ear can very rarely, but sometimes cause conduction abnormalities in the heart. And so that can be sort of life-saving. There's a syndrome called prolonged QT. So this prolonged QT, it's called Jervell-Lang-Nielsen syndrome, and basically parents can sometimes describe these apnea or seizure spells. These children can have sort of pre-syncopal episodes. It can then result in sudden death. It is very rare, and it's only in children who have severe to profound hearing loss that this can occur, but I can tell you that having been in Washington, D.C. now for 2 years, that within 2 years I have detected 2 children on EKG that have had conduction abnormalities that are requiring cardiac medications to sort of regulate. So an EKG is a very simple, inexpensive test to think about. The ophthalmologist is critical too. It's not something you have to send the patient to right away, but oftentimes when they see us and we do confirm that there's significant hearing loss, we want to make sure that this child doesn't have other sensory issues. Children with hearing loss can sometimes develop progressive blindness, and so that would be critical to recognize that if your child can't hear, that they could also lose their vision one day would be something very beneficial for the parents to know. So the ophthalmologist, we forget looking at the ophthalmoscope, but the ophthalmologist is very adept at looking at the eyes and looking for things like blue sclera, which could be a sign of osteogenesis imperfecta, the heterochromia, which I'll show you a slide next, which can be significant for Waardenburg syndrome, and then they have to do a special electroretinogram test, which involves a child going to sleep, but that can determine retinitis pigmentosa, which is an Usher's. Usher's is a syndrome which results in children becoming deaf and blind, as well as having balance issues. So this is actually a child with Waardenburg's. I don't know if any of you have something like this in your practice. You can see the characteristic white forelock, the widely displaced eyes, the shortened ala. These children are at high risk for having significant hearing loss. Dr. Rosenbaum, our geneticist, actually does a superb job of counseling these families. And when patients come to us and we suspect that there's a genetic etiology, of which, as we're realizing, there are genes for pretty much everything. That's not to say that environmental factors, ear infections, meningitis don't play a role, but the genetic factor of hearing loss is very high. It's 75, 80%. And the gene testing before used to be expensive and not very diagnostic. But Dr. Rosenbaum has partnered now with a group out of the University of Iowa doing otoscope genetic testing. And this is oftentimes covered by some insurances, and it tests a large array of genes and can give us good prognostic information. So this is a good little cheat sheet of just sort of when to think about to refer to other specialists. And if there's a family history, if there's concern, if there's for instance, an ABR or Bayer test or failed newborn screening test, and it's helpful to refer both for repeat audiologic testing, and if that's comes back positive, to send off to an otolaryngologist. Some of the labs that can be helpful within the first few weeks of life is this rapid CMV assay, which is a urine shell, which looks for cytomegalovirus, which I'll talk about in a little bit. That's only if the child's less than 4 weeks of age. And some of the key things that are helpful for us is when parents are just gently reminded to bring copies of their audiograms. What are some of the workups that we will likely perform? Oftentimes, we will sometimes do imaging, although with the risk of radiation, we're sort of moving away from imaging as being the first modality, and I think genetic testing in the next 10 to 15, 20 years is going to sort of be mainstream. And we also partner very carefully with our audiologists and our speech therapists because we want these children to get aided with hearing aids right away, and also to get speech therapy and rehab right away. This slide is something that you all are very familiar with. This is an otoscopic exam of a child that has serous effusion, and it's just sort of to highlight one important point. 90% of these effusions will resolve spontaneously. They don't need ear tubes. They just sort of go away on their own. But it's important that we to recognize that to remind parents and remind teachers that when a child has an effusion, it can cause a decrease in the hearing. And you can see that over here, that this right ear is being subtly affected because of the fluid. So I talked, it sort of brings us to the end of the first half of the talk. We talked about the past and what's been going on. We really didn't have cochlear implants. If you were profoundly deaf, then adult sign language was your only modality of communication. We didn't have something called bone-anchored hearing aids. I'm going to discuss on that a little bit later on. We didn't have high-resolution imaging in the past. 10, 15 years ago, we would get x-rays, but we weren't really sure what we were looking at. Now we can identify, for instance, when a child doesn't have an auditory nerve. If a child does not have an auditory nerve, a hearing aid obviously will make no difference for that child. Hearing aids used to have a stigma and weren't socially acceptable, and they had a poor they weren't cool, they weren't hip. And now they're very small. They have MP3 interface. They sync, for instance, in movie theaters. The sound can be streamed into your hearing aid. We didn't have gene arrays, and now we're able to do quick genetic testing. And bacterial meningitis, as you know, had a much higher incidence, and that really was one of the unfortunate things, is they had a lot of neurological sequelae, and a bad bacterial meningitis could really wipe out a child's hearing. And not only that, ossify or turn the inside of the cochlea, which has important electrochemical gradients, but the ossification from the meningitis could then make it difficult to do a cochlear implant. So we have a lot of great stuff that we can now use in our armamentarium to help treat these children. I'm going to touch on that in the sort of next half of the talk. We have high-resolution imaging, which allows us, for instance, to look at something called enlarged vestibular aqueduct. This is important because children who have EVA, or if they sustain significant head trauma, and you guys know about the NFL and football and head concussions, but they've also shown data that kids who are just heading the ball with soccer can have mild concussions. Well, children with enlarged vestibular aqueduct basically are more likely to hemorrhage in the cochlear vestibular area, and that can cause sudden precipitous drop in hearing. So it's important to be aware of that. The hearing aids come in cool colors. We have genetic testing now that allows parents to understand, for instance, if the hearing loss is going to progress. Most connexin hearing loss is stable. It does not get worse. And now we have Hib and Prevnar, which have reduced bacterial meningitis. So the big risk factors, we sort of touched on this, but we also have new risk factors. Children who were 26, 23-week preemies didn't used to make it, and now they're making it. A 24, 23-week preemie is now coming out of the NICU, believe it or not. ECMO now we have it at Children's, and that is a big risk factor. MP3 players have to be sort of carefully managed by the parents because they can generate enough sound that they can cause some hearing loss. HIV, which is now very nicely managed with our retroviral therapy, and our infectious disease colleagues have done a wonderful job with that, but it can have a slow, insidious effect on hearing over time. And there's a new diagnosis, relatively new, it's been around for a few years, but auditory dysynchrony, which is where the child's able to hear but not hear well. So the nerve is able to fire and you're able to hear the sounds, but the sounds aren't allowing that child to develop normal speech and language. There are, as I talked about earlier, the great benefits of universal newborn screening, and just what a great job that's been doing in terms of detecting children early on. It's been a wonderful public health initiative, but it doesn't capture everything. There was this research that I did when I was in Chicago with one of my partners, Dr. Young, looking at the limitations of universal newborn screening in early identification of pediatric cochlear implant candidates. And the take-home message is that if a child passes their universal newborn screening, that does not mean that they cannot develop hearing loss. In fact, 33% of the children who we implanted, obviously there being a bias but 33% of the children who we implanted did initially pass their screening test. And many of these children did not have identifiable risk factors. We are now, because of universal newborn screening, able to implant at a much earlier age. And before the mandate, the average child was, as you can see, 5 years of age. That's just not good in terms of getting good outcomes. We're now post-mandate implanting children as young as I mentioned, 6 months of age, but on average at around 2 years of age. And then we were interested in looking at whether children who had not gotten any screening, whether they did better or worse or the same as children who initially passed the hearing test, but then were to go on to develop progressive hearing loss that would become severe to profound. And it's interesting. The good news is that pediatricians and parents are very savvy at determining whether or not children meet their speech and language milestones. And you can see here that if a child were to get no screening at all, would, so to speak, fall through the gaps, that the average age at diagnosis for hearing loss was 20 months. If you failed the hearing test, we do a very good job of figuring out early on, usually by around 6 months of age, that you do have significant hearing loss. And that determination for severe to profound hearing loss happens shortly thereafter. You know, when a child fails the initial screening test, we know they have hearing loss, but whether it's mild, which sometimes is managed just with speech therapy and sitting in the front of the classroom, or whether it's moderate severe, which requires hearing aids, or whether it's profound, severe to profound, which requires cochlear implantation, that can take a little bit more time to tease out with our audiologists. And then we looked at the age of implantation, and if you were not screened, you were on average were implanted at around 2.6 years of age. If you initially passed but went on to develop progressive hearing loss, then you were implanted at a similar age, actually. But if you failed, then we're actually now able to implant children as young as 1.5 years of age. And there's a lot of data that's now coming out that suggests that the earlier we implant, the better the outcomes. And there's data that shows that if you implant both ears simultaneously, that's better than implanting one and then the other. And then there's data that shows that if the child does not get that sound stimulus early on with the cochlear implant, that there can essentially be sort of atrophy. And so children, for instance, who get an initial implant in one ear and then a year or two later get an implant in the contralateral ear, oftentimes will always prefer that initial ear, which is why we're now implanting them both simultaneously. CMV is our main culprit, we think, in terms of this progressive hearing loss. CMV is very ubiquitous, an incidence of around 2% in live births. We think it's also one of the leading causes of congenital malformation and mental retardation, and it's obviously the most prevalent torch infection. And it can result in significant hearing loss. In fact, if you look, these are sort of the physical exam findings that you can get: petechiae, intrauterine growth retardation, microcephaly, hepatosplenomegaly. But if you look at the incidence here of hearing loss, a third of the children with sensorineural hearing loss, so a third of these children can develop significant deafness. What's interesting is that it can fluctuate and then it can be progressive. And the urine analysis, looking at the CMV, can be helpful because there are studies that are coming out of Cincinnati and Boston that show that use of retrovirals, antivirals, can help rescue this hearing in these children. So this brings me to the last few slides of my talk, where I'm going to discuss some of the surgical updates in terms of what we're doing in otolaryngology to help these children. We have a cochlear implant team at Children's National. We meet monthly. It's a team-oriented approach. We have audiologists, we have speech therapists, we have social workers. We want to make sure that these are the right candidates for the cochlear implant, because there is a lot of therapy that's necessary for these children to do very well. The cochlear implant, as you can see here, has an electrode that curls nicely into the cochlea here. We drill a small little well in the skull, and this is the ground electrode. It is a very thin profile, and in fact, oftentimes it's hard for you to feel it unless the parents sort of point out the scar with the newer, thinner generation of implants. This is a surgery that I performed, showing you sort of the cochlear implant in place. We very carefully drill down onto the dura of the brain, and then we seed the cochlear implant in this well that we've created. And here's the electrode that's going to then be inserted into the cochleostomy, which is a small little drill hole that we put into the cochlea. This is a patient of mine who underwent bilateral cochlear implantation. You can sort of see the device connected here. She's wearing the behind-the-ear speech processor. You can see her here smiling. And just to sort of give you a testimonial of how happy these parents can be. This is an email that I got from a family not long ago. Dr. Riley, my daughter was standing, holding onto the couch. I asked her to get her baby doll. She looked down, looked around, walked to it, picked it up, and brought it to me. This one hit me so hard. I was crying and hugging her so much. So this is a child before the implant who was unable to really hear the sound of her mother's voice, and now obviously is able to do that. I actually do have an audio clip of what a cochlear implant sounds like, so I can play that for you guys if it'll work. Finally, the Baha, which is something that my partner Dr. Choi does in our group. This is very cool. What it does is essentially takes sound and then vibrates the skull and then transmits the sound bypassing the middle ear ossicles to the cochlea, allowing you to be able to hear. This is particularly good for children who have unilateral atresia, because reconstruction of these bones is very difficult, and the result that we get from the Baha is absolutely astounding. So before the child is old enough to get before the child's old enough to get the Baha, children usually can't get the Baha until they're around 6 years of age, because the skull has to be very thick to allow the titanium screw to osseointegrate. The child can, however, wear a soft band that allows the vibrations. And many children, when they put them on, parents are concerned that the child will pull it right off, but actually they enjoy it a lot. So we have our children wear the soft bands before they make the decision about whether to do the bone-anchored hearing aid surgery behind the ear. Finally, what does the future involve? And I think, as I touched on earlier, the future, I think, is going to hopefully involve stem cells. We know that birds can regenerate hair cells. Birds can sustain acoustic trauma and then regenerate hair cells. I did research when I was in Chicago looking at, this is a slide depicting the neurites in the cochlea of a mouse. And the arrows here point to glial cells, which are basically like the helper rescue cells. And damaged neurites, when they get injured, these glial cells come to the rescue, and they secrete these different cell signals, trophic factors that allow the neurites to regrow. Now, they don't obviously regrow in the right direction, but we're studying these signals, these factors, that hopefully one day will allow us to, for instance, instill drops with these factors, or a gel within the middle ear space or within the cochlea that would allow us to sort of rescue the hearing. So in summary, successful screening allows for early detection and intervention. And early detection with appropriate medical, educational, and speech and language therapy allows for a child to reach their full potential with our speech therapists, with our audiologists, with the ENTs and geneticists. And thank you.
So we have time for about 2 questions, and then we'll break so Dr. Riley can answer additional questions outside. So 2 quick questions now, though.
Okay, first question. You said there were about 1/3 of the patients missed. Do you know if they had the DPOE rather than the automated ABR hearing screen in your study? And then is one of them better at picking up sensory neuropathy than the other? And when would you use Connexin?
Well, great. Those are all great questions. The otoacoustic emissions is less accurate and is just relying on the outer hair cells. And that test will not pick up the auditory dyssynchrony, the auditory neuropathy that you're talking about. So that test is cheaper, more reliable. In most places, the otoacoustic emissions is what is used for the newborn screening. The automated ABR test, which is looking at the brain waves and the signaling there, is more expensive, takes more time, and is used more often just in the NICU babies who have the much higher risk factors, the 10 per 1,000 incidence of having hearing loss. So you're exactly right. Our study, it was a little difficult to tease out how those children were tested, but we suspect that many of them did have the less accurate test where they look at the otoacoustic emissions, the echo effect essentially of putting the small little microphone insert into the ear and then looking at how the hair cells contract, as opposed to the ABR, which has much greater diagnostic accuracy. That's a great question. As far as Connexin testing, the way it works with us in our group is that we meet with the family, we talk to them about the genetic possibilities, which sometimes can be as high as 75–80% in these children, if they don't have a history of bacterial meningitis. We send them to the geneticist, Dr. Rosenbaum, who then has them also meet with a genetic counselor and then make sure that the Connexin testing would be covered under their insurance plan. And then we do the genetic testing through the genetics group. Next question.
Yes, Dr. Riley, could you comment about the real or imagined risk for hearing loss after exposure to ototoxic drugs such as gentamicin? Do you rescreen these kids? Is it after 3 days for a rule-out sepsis in the NICU? Is it after a week for a full course of treatment? And then I have a comment.
That's a fantastic question. That area has not been well studied. That is a definite area for greater research because many people mention just what you're saying, that children get brief exposures to some ototoxic medicines. A child who's been in the NICU definitely should be very carefully tested because of the risk factor. If there's a history of an ototoxic medication, I think it's very important. And then the timing of that, I think, is one where I think if the child overcomes the initial infection, then it's something to revisit at a 3 to 6, 9 month sort of interval. Children who undergo chemotherapeutic regimens at Children's National with our oncology, hematology group are very carefully screened pre-chemo treatments to make sure that they have normal hearing, and then do get serial audiograms sometimes throughout the duration of their treatment to make sure that there aren't any dips in the hearing.
And then I just had a very quick comment. I presume you didn't mention it because of the controversy, but the assumption that that parents of all deaf children indeed want and support cochlear implants in a deaf community that actually values the deafness more than the hearing. Again, probably a subject for an entire CME in and of itself, but
Right.
just so that we don't lose the fact that many parents of deaf children who are themselves deaf will actually decline
Correct.
cochlear implant for very good reasons.
And we're very understanding of that at Children's National. We only want children to be implanted if the parents feel that it would be beneficial. We carefully lay out all of the benefits, which we think are great, but there are also risks. It is surgical hardware that is implanted in the child. There is the risk of developing meningitis. There is the risk of the device failing and not working, although there is a 10-year warranty. But so important to the success of the cochlear implant is parents willing to bring that child to therapy. And so we believe strongly that the parents who use adult sign language as their main modality of communication, if they do not want their child to be implanted, then that is their right. Thank you. Thank you all.
Thanks, Dr. Riley. Okay, so we